A paraesophageal hernia, PEH, is a type of hiatal hernia where part of the stomach herniates into the chest through the diaphragmatic hiatus alongside the esophagus. Unlike the more common sliding hiatal hernia, in PEH the gastroesophageal junction remains in its normal position while a portion of the stomach protrudes above the diaphragm. This condition can be asymptomatic but may lead to serious complications if untreated. Classification: paraesophageal hernias are classified into four types. 1. Type 1, sliding hernia. Not a true PEH. The gastroesophageal junction and part of the stomach slide upward through the hiatus. 2. Type 2, true paraesophageal hernia. The gastroesophageal junction remains in place, but the fundus of the stomach herniates through the hiatus. 3. Type 3, mixed hernia. Combination of sliding and paraesophageal components with both the gastroesophageal junction and part of the stomach herniating into the chest. 4. Type 4, complex hernia. Herniation of other abdominal organs, e.g. colon, spleen, pancreas, along with the stomach into the thoracic cavity. Etiology: paraesophageal hernias occur due to weakness or enlargement of the diaphragmatic hiatus, chronic increased intra-abdominal pressure, e.g. obesity, heavy lifting, coughing, or straining, congenital diaphragmatic defects, age-related degeneration of the phrenoesophageal ligament. Symptoms: while some patients are asymptomatic, others may present with gastrointestinal symptoms, heartburn, dysphagia, difficulty swallowing, postprandial fullness or bloating, epigastric or chest pain, nausea or vomiting. Respiratory symptoms: dyspnea, shortness of breath due to lung compression, chronic cough or recurrent pneumonia from aspiration. Severe symptoms, complications, gastric volvulus, twisting of the stomach, causing acute severe chest pain and obstruction, ischemia or strangulation of herniated stomach tissue leading to necrosis, anemia due to chronic blood loss from erosions or ulcers, Cameron ulcers. Diagnosis: the condition is typically diagnosed through 1. Imaging studies. Chest X-ray may reveal air fluid levels in the chest or mediastinal widening. Barium swallow study, best for visualizing the anatomy and confirming herniation. Computed tomography, CT, useful for detailed visualization of the hernia and its contents. 2. Endoscopy, identifies mucosal abnormalities, ulcers, or inflammation related to the hernia. 3. Manometry and pH studies, evaluate esophageal motility and acid reflux if suspected. Management depends on symptom severity and the risk of complications. Conservative treatment: asymptomatic or mildly symptomatic cases may be managed conservatively with proton pump inhibitors, PPIs for reflux, lifestyle modifications, e.g. weight loss, dietary changes, avoiding heavy lifting, avoiding late-night meals, and elevating the head during sleep. Surgical treatment: indicated in symptomatic cases or those with complications, such as gastric volvulus or strangulation. Common surgical approaches include 1. Laparoscopic repair, reduction of the herniated stomach into the abdomen, closure of the diaphragmatic defect with sutures or mesh reinforcement, fundoplication, wrapping the stomach around the esophagus to prevent reflux. 2. Thoracotomy, reserved for complex or recurrent cases. Prognosis: outcomes are generally excellent with surgical treatment, especially if performed before complications occur. Unrepaired paraesophageal hernias carry a risk of life-threatening complications like gastric volvulus or strangulation. Prevention: maintaining a healthy weight, avoiding activities that increase intra-abdominal pressure, timely treatment of chronic cough or constipation to reduce strain on the diaphragm. If you need further details or help understanding specific aspects, feel free to ask.